Very good morning. Today we have a special guest for ISO MVR CanCon 2024. He's the first transplant surgeon in Kerala. He's a doyen in the field of transplant surgery, and he has so far performed more than 1,300 transplant surgeries. It's an honor and privilege to introduce the guest of the day, Dr. S. Sudhindran. He's the chair and head of the Transplant Surgery Division at Amrita Hospital, Kochi. So welcome to ISO MVR CanCon 2024.
Thank you so much.
I'm deeply honored to have you here.
Honor is mine.
Sir, how do you see the future of transplant surgery in Kerala as well as in India? What is the road ahead?
So Kerala actually, interestingly, Kerala actually has the third number of transplants in the country. So Delhi has got the maximum number, followed by Tamil Nadu, and then it's actually Kerala. So, and here obviously the number of patients who actually require transplant is so many. I mean, rough estimate is something like 2 lakh. It's a huge number. So roughly, and the ones who will require transplantation is almost from our state. If you extrapolate the number from US, in Kerala itself, we need at least 5,000 transplants every year. So we're doing hardly 200, 300 transplants totally. A lot of centers are coming up. So there is no doubt that the transplantation number is going to go up. More centers are going to come. So, and the indications also are increasing slowly.
The demand is more, the supply is less. Right. Sir, you have, what are the collaborations you have with the government? I think Amrita Sanjeevani is there.
So sadly, I mean, because it's an expensive procedure, I think it's difficult to depend purely on the government to spend that amount of money. For example, I mean, if for a transplantation, usually the cost will be, even at the government setup, it'll be almost 15 lakhs for a person. So should they spend that on one person, or should they spend on things like dengue, diarrhea? So many other things are there, which also requires attention. Therefore, the priority for the government is much lower for transplantation. But still, the two governments are doing. Two government medical colleges have already started doing. So Amrita, we have like a, unwritten MOU with Kochi Medical College. So, and we help, we do help them and then manage the transplantation. So they have the setup for that. We come and give our technical help whenever it's needed. I think that's the way it's going to progress. We have to have public-private participation for this to progress.
Sir, you started the program in 2004, right? So it's almost 20 years. So can you share your experience in transplant over the years?
So the first transplant, so I had my experience in transplantation from UK. So after I came back here, so everybody was saying, transplant is not going to happen. So the first transplant itself, I think basically the problem is we are all used to disease donors. And so our initial plan was also to go with disease donors. But sadly, awareness was not there. And so the first transplant actually happened because the donor's son, donor means it's a brain dead donor. His son was a cardiologist working in US. So when he realized that his dad was brain dead, he asked can donation be done? So and that is how it actually started. So that time we had the donor, but there was no recipient. So and then we just looked around the hospital, and there was this gentleman, 32-year-old guy with a hepatitis B, a deeply in fulminant hepatic failure, very bad. I mean, very poor family. So the medical director and Mata Amrita, they agreed. I mean, it will be given free. And but he was very sick. I mean, in the sense. So I still remember. I mean, he completely comatose. They were recently married, and so they were taken to theater. The first transplant, that's going to happen. And the wife, so how just getting into the ICU, she came and just, she was on the bed comatose and just, kissed him on the lips. And she was crying, obviously. And then I thought, oh my God, this is going to be the last kiss. It's unlikely it's going to come out. But fortunately, I think everything went very smoothly. And he immediately recovered. And 3 weeks later, he was discharged. And that time, the government came and gave him the antiviral medication. It was very, very expensive that time. He had it for 2 years. And then the government stopped. And then the medicines didn't come. And then he got a recurrence and he died subsequently.
It's one of the most cherished moments in the life of a surgeon.
Yes, yeah, definitely, yeah.
So you've been doing liver transplant for hepatocellular carcinomas and all. So how do you see the scope of services in primary biliary tumors as far as transplant is concerned?
So as a rule, intrahepatic oncology was a contraindication. So the Klatskin type tumors, which were infiltrating the blood vessels. So unlike in hepatocellular carcinoma, in cholangio, invasion of the blood vessel is not a contraindication, and usually it becomes a contraindication for surgery. That is how the original protocol, Mayo protocol, etc., started. And then, but sadly, I mean, like I said, I've been, every single patient that was unresectable, we've been trying to, to find a way through transplantation. But out of the 1,300, there's not even one patient who's had a cholangiocarcinoma. But recently, reports have come for intrahepatic cholangio as well. So maybe it's going to come. But as of now, because evidence is not there, and predominantly we do live donor transplantation, so you want a reasonable result. So we've still not managed to find one yet. But I think it is the scope is there.
So this year our theme is salvage, pushing the boundaries for cure. So we have new molecules like immunotherapy coming into the, even we have neoadjuvant immunotherapy coming in. So do you, I think there is scope for.
I think so, yeah, definitely, I think so.
Down the lane we will have solutions,
Absolutely,
right?
yeah. Because I think almost all GI cancers are moving that way. You do neoadjuvant and then go for surgery. Almost every one of them is going that way. So even with cholangio and hepatocellular carcinoma, I think that will be the way forward. Because essentially, it's going to be a not just surgical treatments. A lot of pre-surgical treatment is required, particularly for selecting the patients. The ones that respond well are the ones that are going to respond to surgery as well. So yes, definitely, I think it will come.
The future liver remnant is a very important concept when you come to hepatic resections. So how do you assess that in a post-neoadjuvant setting?
Very, very difficult because particularly in our patients, I mean the fatty liver, so-called metabolic associated steatotic liver dysfunction is actually very, very high as it is. And once they undergo chemotherapy, it becomes even worse. So sadly on the CT or even the MRI PDF of proton density fat fraction, that doesn't come up very well because the chemotherapy induced steatohepatitis or venous occlusion, sinusoidal syndromes and all that is not very well made out on the thing. So assessing the liver remnant is very bad. So as a rule, we should have minimum 40% or 45%. That should be an absolute minimum for post chemo induced. Preferably, I would like 50%.
So there will be some lesions initially in our initial evaluation, CT or MRI. So after chemo, these usually disappear. So how do you follow up these disappearing lesions?
Very, very difficult actually. If it's on the superficial area, yes, we can. But the deeper ones, it's always very difficult to follow them and especially to find them out and take it out. Because how do you find them on table also is very difficult. So I think the one policy which most people do is give 2 or 3 cycles and then once they start responding, then go for surgery rather than continue the chemo and completely disappear. So because that again tells you that this is a guy who's going to respond to treatment. So before it completely disappears, I think probably we should go and excise it.
So in simple words, can you enumerate what are the current indications for liver transplant as of now?
So 80% are for chronic liver failures. Chronic liver failures. In our setup, if you look at the last 2 years, 30% has been for alcoholic cirrhosis. Another 30% has been for non-alcoholic or so-called metabolic associated liver dysfunction. That is, they don't consume that much of alcohol, but because of diabetes, obesity, other metabolic risk factors, they have. So that is actually growing, and the way it's progressing, it's going to overtake alcoholic liver disease. Then another set of group of patients with hepatocellular carcinoma may be there, or other disorders. And children are there, pediatric population is there. And then finally, in about 10 to 15% actually acute liver failures. So predominantly rat poison is an important rat poison. Yeah, almost last year also we had like 7 or 8 patient rodenticide, yellow phosphorus poisoning, hepatitis A, hepatitis B, non and non-B hepatitis, drug-induced anti-tuberculous drugs, some Ayurvedic drugs. So these are all other 15% is acute liver failures.
Sir, any experience with colorectal liver mets for transplantation or any scope for it?
Well, definitely, yes. Because the recent, I think, last publication, they've actually done a randomized trial. It's not published yet, I think, but they've shown a 10-year survival, no, 5-year survival of almost 70% for huge colorectal mets which are not which are not resectable, and they actually responded to chemo, but then they have come back again. And interestingly, the recurrence, even in those group of patients, was not in the liver; it was actually lung, more than that. And even there, also they went and resected. So the problem has been always the disease donor availability, which is why it never happened. So it was only in Scandinavian countries where it started, where they have a surplus of organ, not surplus, but they have enough organs. So living donor, when it comes to living donor, it again becomes a little bit of a dodgy issue, because they've already exhausted so much of their money with all this. Now the chemotherapy is so expensive, immunotherapy, all those things. And so then the money comes in, and then you're not able to guarantee them that this is going to work. So, but I think slowly, I think it's going to improve. So the field of transplant oncology has come. So colorectal mets, even breast cancer mets, some people have operated. Cholangiocarcinoma is coming, intrahepatic cholangio is coming. So
Sir, having said that, a question about transplant oncology. Yesterday we had discussions about recurrent pseudomyxoma peritoneum. So the Dr. Fujiti from Cleveland Clinic, he was discussing about the scope of small bowel transplant, multivisceral transplant, and recurrent unsalvageable pseudomyxoma peritoneum. So what is your experience on multivisceral transplant surgeries?
So we've done 4 multivisceral, means modified multivisceral, small bowel plus liver we haven't done. Surgery itself is technically not that difficult, because it's a whole thing explant, and then anastomose also is technically it's not that difficult. But post-operatively, I think the risk of the problem with small bowel transplantation is that rejection rate is very high, because a lot of lymph nodes is there. So once you have rejection, your mucus permeability goes up. So then your transmigration bacteria occurs, and then infection occurs. So when you have rejection, you obviously have to give anti-rejection therapy, which are actually immunosuppressants. So, but rejection also enhances the infection rate, and that is it's a very difficult thing to manage. So most of them succumb to infection. That is a problem. So out of the 4 that we did, actually 3 died, only one, but one is doing really well. So, but this group of patients may be slightly better in that they're actually not being done for transplant, for small bowel failure, but they're being done for oncological clarity. So once that evidence comes up, so that may be possible. But again, the issue in Kerala as of now is lack of disease donors, because there is hardly anything is happening, less than 20 per year. So that is a problem.
I think there should be more awareness with the public, right, in disease. So you'll be practicing more on live donor liver transplantation.
99%.
99%. Okay. It was an honor to host you, and it's a privilege. And the happiest part is that we share the same alma mater.
Yes,
so
yeah.
that's a special.
Special bond.
Thank you, Dr. Sudhindran. Thank you for your time, and thank you for being part of ISO MBR CanCon 2024. Thank you.
Privilege is entirely mine. Thank you, Gokul. Thank you.